Today, we discussed the importance of shared decision-making. We reviewed clinical data from PARPi and ARPI trials, noting that some combinations are effective in both molecularly selected and unselected mCRPC patients. A treatment decision is a very individual decision, and personal goals need to be taken into account, as well as the efficacy and potential side effects for each patient. Welcome to this video on shared decision-making in prostate cancer. We'll use a patient's case to highlight key concepts. Let's consider why shared decision-making is important for men with advanced prostate cancer. Involving patients in treatment decisions ensures they understand the potential benefits and risks of treatment and empowers them to choose that they match their personal risk tolerance and quality of life priorities, leading to better side effect management, adherence, and outcomes. SHARE is a communication framework. Its aim is to improve the quality of interactions with your patients. This includes the engagement in shared decision-making, as well as ultimately having a positive impact on treatment outcomes. SHARE's 5 letters each represent a crucial communication point in your conversation with the patient. S stands for success criteria and aim of treatment. H stands for how the treatment works. A includes advantages and disadvantages of each treatment option. R stands for risks and effective management of side effects. And E finally aims to capture the expectation for treatment success. So now let's go to our patient's case. This young gentleman was diagnosed with a de novo metastatic prostate cancer in the age of 53 in November 2021. Staging examinations revealed a lymph nodal metastasis as well as a single bone met at the time of diagnosis. From November 2021 to June 2024, the patient received an intensified hormonal treatment with androgen deprivation therapy combined with enzalutamide. Unfortunately, in June 2024, a rising PSA was recognized in the routine laboratory workup. A PSMA PET scan at the time revealed new metastasis in the lymph nodes, as well as a new bone metastasis in the ribs. When discussing the results with the patient, he emphasized that his prior goal was to attend the graduation party of his oldest daughter and thus maintain the quality of life. As this patient is now castration resistant, tumor tissue testing was performed accordingly. Results were negative for BRCA1 and 2, and testing for the other genes actually failed. We have to consider that his HR status is actually unknown or negative. So one option would have been a classical chemotherapy with docetaxel. However, because the patient wanted to maintain quality of life, he denied chemotherapy. Another option would have been the application of abiraterone in combination with prednisolone. However, sequencing abiraterone after enzalutamide is known to reduce the activity of the androgen synthesis inhibitor. Newly approved in the setting for an all-comer population are 2 combinational treatment approaches with an ARPi and a PARP inhibitor. One combination is the combination of olaparib and abiraterone, while the other combines enzalutamide and talazoparib. However, keep in mind that our patient has been pre-exposed to enzalutamide in the hormone-sensitive setting, so this was not really an optimal treatment approach at the time. Please note, while clinical trial data support the combinational treatment approach of PARPi and ARPI combinations, approved indications may vary by molecular profile. And please always refer to local guidelines and prescribing information before making treatment decision.